Good morning. Kathy Brown. Nice to meet you. I am. Public health. Public health. Yeah.
I'm going to ask you guys to just do your own brief introduction.
Okay.
Kind of how you want to be known.
Yeah.
Sure.
That's okay.
Sure.
All right.
Absolutely.
So don't let me scoot to the left. Don't have one on margin here. There you go.
Good morning. I'm Joel Christopher. I'm executive editor at Knox News. Thrilled that everyone's starting their morning off with us today. We know it's difficult for people to make time during the grateful that you're all here. We have an important topic in front of us today, and we have industry experts here that are going to guide our conversation, and we thank them for making the time and effort to join us. Knox News is proud to be the voice of East Tennessee, and it's through events like this that we really get to the heart of the issues that are facing our community. Before we begin our discussion, I'm pleased to invite today's sponsor to the stage to say a few words on behalf of the Tennessee Healthcare Hall of Fame. This organization seeks to recognize and honor the pioneers and current leaders that have formed the Tennessee health and healthcare community and encourage future generations of healthcare professionals. Please help me welcome Matthew Seaton.
Good morning. How's everybody doing? Good. Thanks for giving me a few minutes of your time. My name is Matt Seaton. I am with Belmont University in Nashville, Tennessee, representing the Tennessee Healthcare Hall of Fame. And Joel, you messed this up just a little bit for me, but that's okay. Has anybody heard before Joel mentioned it about the Tennessee Healthcare Hall of Fame? Raise your hands. Got 1, 2, 3. Perfect. That's exactly why I'm here today, is to talk to you about it. Before I launch into exactly what we need your help with, I'm going to give you a little background on the event itself. So back some members of the healthcare community were grappling with a question, and that question is this: is how do we kind of stamp the state of Tennessee as the center of the healthcare industry for our country? What are some of the things we need to do? And as they were grappling with that question, they realized that a lot of the same names kind of started popping up, right? Frist, McWhorter, Danny Thomas, Lynn Massengale, so on and so forth. And as these discussions kept going on, the names kept bubbling to the surface, and they kind of realized, hey, this is about people. These are about people who have really laid the groundwork for probably a lot of the great work that we might talk about today, but also a lot of the work that's being done in places that we don't even know about that is being done right now. And so a very unique opportunity was presented to Belmont about helping organize and plan and execute an event that would recognize pioneers in the healthcare industry based here in Tennessee. These people can be obviously practitioners, they can be scientists, they can be educators, they can be legislators, they can be policymakers, they can be just about anything that you can think of that is contributing to the many, many different fields of healthcare here in Tennessee. And really, it's just about acknowledging their commitment and their contribution to making the state of Tennessee kind of the center of the healthcare world here in the United States. So fast forward a little bit to the fall of 2015, we inducted our first class. And in this past May, we just got done announcing our 5th class of inductees. And the Hall of Fame event induction ceremony will occur on October 15th in this fall. And here's where we need your help. So at the end of that event, one of the last things that we will talk about after we've been able to celebrate all of these great people, all of the new inductees, there will be a call to action. And that call to action is to open up the nomination window and to now put things into your hands because we need your help. We need to know who are these people? Who are the people who have made a lasting and significant contribution to the healthcare industry here in Knoxville? I'm sure even as I'm saying that there are plenty of names that are just kind of circling in your mind. And what we need to do is get those names out of your mind and put them down on paper so that we can do the legwork to acknowledging them and to getting their portfolio in front of our selection committee, which is made up of healthcare leaders from across the state of Tennessee. So that's really where we need your help, and that's really what I would love to help with today. I'll be here for the event. I'll be here after. We have got some brochures that talk about the event on the back table, and I'll be here to answer any of your questions. But really what we would love for you to do as you leave here today is to be thinking about the big names of people, men and women who have really, really contributed, not just here in Knoxville, but really across the state and really across the world. And if you have any of those names, I would love to hear them, and we would love to connect with you so that we can make sure that those people are getting nominated for this great event. So thanks so much, and thanks for holding this event, and thanks for this important conversation. We'd love to be a part of it all, so thanks so much.
We're thrilled this morning to have U.S. Representative Dr. Phil Rowe with us. He's the ranking member of the House Committee on Veterans Affairs and a veteran himself. And as such, he has insight on the healthcare needs of our most sacred citizens, our veterans. Without further ado, U.S. Representative Phil Rowe.
Get out of the way. Thank you for the brevity of that introduction. It's good. I really appreciate the opportunity to be here today. You know, Congress only has a 10% approval rating, so we're glad to get invited anywhere. So thank you for having us. It's good to see my good friend Patrick Wilson sitting over here. Patrick and I have gone to church together for a number of years, and I've had the privilege. He has raised a great family. Two of his boys I've had the privilege of appointing to the Naval Academy. One's getting ready to go in about a month, and I saw him this weekend. He's a very excited young man, Patrick. So thanks for coming today. You know, as you get older, there are telltale signs, and one of the reasons I knew I was getting older was I keep getting these unsolicited emails for the walk-in tub. I don't know about you, but it's happened to me regularly. I wasn't exactly sure what this symposium was about, so I'm going to just fly by the seat of my pants. I'm going to tell you a little bit about the VA system, and then I'm going to go about where our healthcare system is in this country. I grew up in Clarksville, Tennessee, and went to Austin Peay, went to medical school at the University of Tennessee, Memphis, and then, we have an all-volunteer Army, and I actually volunteered in the mailbox one day. I got drafted is what happened, and I was drafted in the middle of my residency in Memphis, so it took me 6 years to get my residency done in OBGYN. I moved my young family to East Tennessee and just started practicing medicine and building a practice. And I could see the changes. I know these physicians certainly have, and in my now 48 years as a physician, I've seen tremendous changes. Our small OB group were 4 of us, and I realized during the 80s, 90s, healthcare was changing. So we, in the 90s, grouped together. Our practice now is State Franklin Healthcare. We have 120 providers and about 450 employees in our practice. And unfortunately, like small banks, like small pharmacies, small medical practices are having a very difficult time surviving in this current environment that we have. And a few years ago, people said, Bill, why did you run for Congress? And I said, well, the truth is, I went off my medication. I had a perfectly good practice. I enjoyed it, but I thought it was time to serve. I served in Korea in the Army near the DMZ in the 2nd Infantry Division. And I thought I could continue practice for a while, but I really would like to get involved in policy of medicine and this country. So I was it was a perfect fit for me, the VA, because much of what the VA does is health care. And when I got to Congress in 2009, the VA's entire budget, that's for health care, disability benefits, and cemeteries, that's the 3 prongs that they have, was about 97.5 billion. The president's ask this year is $220 billion, and that's in a discretionary part of our budget, which has been pretty tight, if you follow it. But both presidents, Obama administration and the Trump administration, have been very supportive of the VA. About 90 billion of that will be in healthcare. When I looked there, it was very fragmented. There were 7 different ways that you got care outside of VA hospital. In 2014, the VA underwent a scandal that you probably recall in Phoenix. What was happening was they had a metric about how quickly did you come in and get to see the doctor. And what they did in Phoenix was they brought you in and put your name on a piece of paper, but they didn't enter you into the electronic health system that they had. So you never showed up until somebody moved off the electronic record that moved you from the paper record in, so it looked like you were getting seen quickly. And what happened was many veterans died because of that. So we started the choice program we passed in 2014. We got it done in a bipartisan way, and what we did when I was chairman of the committee last Congress, I thought we have a unique opportunity now to really passion about how health care is provided in the VA. So if you were a veteran and you came to the VA, there was 7 different ways that you got your care cared for outside of VA hospital. What I did was wrote a bill, and I set everybody down in the committee, Republicans and Democrats. We left all that stuff at the door, and we wrote a bill which we hope will be transformative for VA. It does the following. It says now there's one way when you get VA care, and there are access standards about how you get that care. In other words, how far you live, drive times. If you live here, a drive time is not too bad. If you're on the 405 in Los Angeles, which I've been visiting out there, you could be 2 hours from somewhere if you have to get on the interstate. So we calculated drive times, and we had to create a plan that worked for both rural America and for urban America. And what I meant by that, I was out visiting a friend of mine, Greg Walden, in Oregon about a year ago, and his 1 congressional district has more square miles than the state of Tennessee has. So you see the challenges that we had in trying to get for rural America and for urban America. That bill, so we have that. That goes live the 6th of June. The second part of that bill, which I thought was very important, was a caregiver bill for catastrophically injured veterans. And there are many that I have met across this country, and I do mean catastrophically injured. Post 9/11, if your husband or wife stayed home with you to take care of you, then we provided a stipend and health care for them. But if you're pre-9/11, as I am, Vietnam era, then there was no one to take care of you if you had a service-connected disability that prevented you from working. So now we're putting a process in. We passed so that where World War II veterans, Korean War, Vietnam, as I am, also have access to that. Thirdly, we know there is a huge workforce issue at the VA. And we're providing, paying student loans off. That's also put in that bill, and expanded the number of residency spots. And I know for our educators here, that is a huge problem, is finding slots. And lastly, we did something called an asset review. The VA has 6,000 buildings that they look after across the country. 1,100 of them are not used or only partially used. And this was an amazing statistic to me, that in 1981, hospital heads in beds and hospital beds peaked in 1981. Our population has grown by 40% since then in this country, and yet we have 10% less people actually in a hospital bed. And that's a real challenge for our hospital administrators and so forth. And why is that? Well, I'll use myself as an example. I've done thousands of operations, surgeries on people. Had never had an operation on myself until 2 years ago. That's why I'm getting these walk-in tub heads, I think. Anyway, I herniated a disc climbing Mount Katahdin in Maine, and I had to have back surgery. Then, about a year and a half ago, I had prostate cancer and had robotic prostate surgery. Spent less than 48 hours in the hospital for both of those. So we are now doing so many things as an outpatient that there's going to have to be a real look at our hospital administrators about how the bricks and mortar folks I'm talking about, because more and more and more is going as an outpatient. Now, I'm not going to spend any more time on the VA. I want to sort of talk about our healthcare system in general in this country, because it is fragmented. the system in America is, I'm going to run through it, and then this is the policy I hope these folks are able to talk about a little bit. About 180 million of us get our health insurance through our businesses, through our jobs, or our families do. Then we have Medicare, which is about 47 million of us get our care through Medicare, plus about 10 million either that are added to Medicare through a disability. If you're on dialysis or you are disabled, Social Security disability, after 2 years you can qualify for Medicare. So we've got about 57 million people there. 180 million people get their insurance through private carriers. Then you have the Medicaid system and the CHIP system, which most are children, but that's about 70 million people. And remember that the old Medicaid system is run, the Medicaid system is run by the states, but there are actually now two parts of it. One part of that system is the part that for the disabled and elderly and children. The other are the able-bodied, and that's what the ACA, the Affordable Care Act, brought along. So now we get to the Affordable Care Act, and what it did, the premise of the Affordable Care Act was to lower costs and increase access. It has not actually done that. In Tennessee, the costs have gone up 176% during the last 8 or 9 years. And the problem with it is it made it unaffordable for some people. And to give you an example, in the 1st Congressional District, about 20,000 people have ACA insurance coverage. But about 15,000 people chose to pay the penalty or a tax because they couldn't afford it. I have ACA insurance, and my premiums each year are about $20,000 a year for me. Now, I can afford that, but a lot of people cannot afford that. And I talk to people all the time, so we need to look at how we make insurance coverage more affordable. So I've kind of gone through our system, and then you have the uninsured. And we have the health department here, and I have been a huge supporter of our federally qualified health centers. We have 55 clinics in the 1st Congressional District, and they are incredible assets to rural areas, to our communities. I'm going to talk about something Tony's going to like hearing me talk about. I feel like Moses in the desert. I've been talking about this Medicare wage index forever. And finally, I got somebody to listen to me. Let me explain what that is for you all that don't know. Our hospitals are funded, probably, Tony, what, 60% of your, maybe, are Medicare patients, 50, 60%. Well, when they're funded based on a wage index. And the wage index says this: if you live in Knoxville or you live in Johnson City, your cost of doing business is less than if you're doing it in New York City or somewhere else. And nobody ever intended for it to get like this. But we get paid right here. Knoxville and Johnson City have the 2nd lowest wage index in America. And it's 0.71 cents. So we get 71 cents for what we do, for what somebody else gets $1, or if you're in California, as much as $2 to do exactly the same thing. And I'll show you how politicians, I was a little naive when they wrote the Affordable Care Act. I couldn't not figure out why one hospital in Massachusetts was in there and why 4 states out west were in there. Well, I should have been a little smarter. It took me a few months, but you know, I'm just a country boy from East Tennessee, so not too smart. But I did figure it out. Senator Kennedy was a very powerful senator. He put one hospital in the Affordable Care Act that had the highest wage index in Massachusetts. So all the other hospitals paying off that one very high wage index, so they get paid more money. Max Baucus was the Senate budget chair, and he put Montana, South Dakota, North Dakota, and Wyoming, the so-called frontier states, they all get $1. Well, I can tell you, if he got $1, he would need a dump truck to haul the money out in. That's how disparate it is. And there are 3 states, I told Secretary Azar, if your job, if your purpose is to put rural hospitals out of business, you are succeeding. Texas, Tennessee, and Alabama have the lowest wage indexes in the country, and guess who's had the most rural hospital closures? Texas, Tennessee, and Alabama. And guess what happens when you lose your hospital in your community? You're done. Nobody's going to move into your community, and it's happening in our state. We've had 11 closed in the state of Tennessee, and I've seen it in Southwest Virginia. Now, those are the Secretary Azar is the Secretary of HHS, and I begged with him, pleaded with him, and let me just be purely political here. There was not going to be a political solution to the wage index. Why? because Nancy Pelosi is the Speaker of the House, and she's from California, and my leader, the Republican leader, Kevin, is also from California, Bakersfield, California. So we weren't going to take money away from California. But it looks like they're going to be able to do it through rulemaking. And what's going to happen is that bell-shaped curve, we're going to move it in so we get a little bit more. The very top gets about a 5% break. And let me just go quickly on how this system is scammed and used. He can't directly hire a doctor. You have to have a contract with, unless you're at the university. You can't have you have to have a contract like radiology or anesthesiology, the guys in the ER, those folks, hospitalists, they have a contract with the hospital. Hospitals in New York can directly hire the doctors. So what they will do is they'll go to Sodexo or Marriott or some service company and say, hey, you guys are really good at doing environmental services and food services. Well, guess what are the two lowest paid positions in your hospital? And the highest paid positions are physicians, so you turf those out to a Marriott or a Sodexo, and your wage index goes up and you get more money. So I won't rave on that anymore because it lights my pants on fire, because they're putting us out of business, and we're doing the same thing. A CT scanner costs him exactly the same thing as it does in California. So when I've raved enough about that, we have I'm going to talk about some really good things that are going on and some challenges. Folks, we have a huge challenge in Northeast Tennessee and across this country on the opioid crisis. When I looked at the people that died of prescription drug or illegal drug overdose deaths last year, 72,000 people. More people died than in the 10 years of the Vietnam War. Think about that. I did roundtables about 3 weeks ago during the Easter recess. We did two with our law enforcement people, our educators. We did an opioid and sexual trafficking. And it is unbelievable. When I was in 1998, when I was delivering babies, and I can also tell you that I've delivered about 5,000 babies, and that comes in very handy when you're running for Congress, when you've delivered your own voters. I can tell you that. It worked out well for me. But there were 50 in this entire state, 50 opioid-addicted babies in 1998. And in about 2012, fortunately, it's gone down a little bit, but it was 1,000 babies a year. And these are children that have these, I mean, if you've seen these withdrawal in the NICUs, it is really unbelievably heartbreaking to see that. It's down now to about 800, but that's still a huge epidemic in a state where 800 children, the educators have got to deal with them, social services, I could go on and on. We have a mental health crisis in this country, and the two are tied together. When I graduated from medical school in the state of Tennessee at Eastern State, Central State, Western State, 4,200 inpatient psychiatric beds. Today, we had 500,000 beds across the country. Today, in this country, we have less than 50,000 inpatient beds. I talked to a guy, and I won't say where, but it was a town in this area he is an EMT. He works on weekends, but he's a public official in that county. Went there one weekend, a guy was in the ER in a room because he needed a psychiatric bed. He went back a week later, the man was still in the same room. That is not acceptable in this country to do that, to treat people like that. So we have got to reinvigorate and expand our mental health services in this country. And that's one of the things that we need to, and there are many educators here, but we need to get a robust workforce, our medical workforce. We're going to be 130,000, maybe more, doctors short by 2030. That's 11 years from now. If you take a student, 18-year-old, maybe one of Patrick's sons will want to do that, it'll be 2030 before they're educated, completely educated. Drug prices, another huge problem we have to deal with, that we're dealing with in Congress right now. And then I want to finish by the positive stuff. I've gotten to be friends with Dr. Francis Collins, who's the head of the NIH. And I told him the other night at a dinner I saw him, I said, Dr. Collins, I'm a fiscal conservative. I'll about write a check for anything you want to do. I mean, they're doing some of the coolest stuff you have ever seen. And I want to go back through my medical history a little bit as a physician. When I graduated from medical school in 1970, when I was a student, in the late 60s, the first inpatient rotation I had was St. Jude's Children's Hospital. And we have a branch in Johnson City at our medical school there, which I taught at the medical school for many years. 80% of the children died when I saw those kids. I knew when I put an IV in one of them, they were most likely going to die. Today, 80% of those kids live. Number two, when I got out of school, we had a disease we didn't even know the name of. We knew it was there. It was hepatitis C. We've gone from a disease we didn't know the name of to now you can cure it in 8 to 12 weeks with a 98% certainty. I look at sickle cell anemia. Dr. Lemuel Diggs was my hematology professor. Dr. Diggs spent his entire life trying to cure sickle cell disease. I sat by bedsides myself and have done exchange transfusions on pregnant women so they wouldn't die or their baby wouldn't die. Today, Dr. Collins, with the work they've done at NIH, takes a piece of attenuated HIV virus and moves a gene to that spot, that's that genetic error, and cure sickle cell disease. That is an amazing thing that's going on. There's 7,000 genetic diseases out there that we think we're going to get cured. And it's coming so fast, it's amazing. And I wish I was back in the examining room. And I could spend the entire day talking just about what's going on at NIH and our future. I think the future is great. There are huge challenges in this country, but we're up to it. You have an incredible panel put together here, the people that are on the ground providing care every day. And I want to thank them for what they do each and every day to get up and make the life of our citizens better. I appreciate the opportunity to be here, and I hate to speak and run. My staff had written a really nice speech. They're going to be upset that I didn't read it to you, but anyway, I didn't. Thank goodness you didn't have to hear me read a speech to you. But I appreciate you coming out and being interested in your community and making life better for the people that you serve. So thank you all very much.
Hi, I'm Christy Nelson. I cover health for the Knoxville News Sentinel. I wanted to thank you all for attending this morning and to thank our panelists for being willing to sit on a panel about this important topic. Going to introduce our moderator, Dr. Keith Gray. He's the Senior Vice President and Chief Medical Officer at UT Medical Center. He's practiced surgical oncology there for 11 years, and he's also served as Chief of the Division of Surgical Oncology, Chief of Staff, Medical Director of multiple service lines, and he co-founded the Physician Leadership Academy. He has a Master of Business Administration degree also from UT, and he's delivered more than 100 community lectures on health equity and eliminating health disparities in East Tennessee. He's also a trustee of the Emerald Youth Foundation and the East Tennessee Foundation, and he advocates for patients battling cancer and mentors people pursuing careers in healthcare. So I'd like to welcome Dr. Gray, who will introduce our other panelists. Thank you.
Thanks for the opportunity to be here, and I want to thank Knox News for recognizing health disparities and promoting health equity as an important issue in our community and all over the country. I want to start by saying I got involved in this community in promoting health equity by delivering one of those talks, and I realized pretty quickly I didn't know anything. I was over at the Beck Cultural Center, and I was delivering a talk about cancer care and how to prevent cancer. I said 2/3 of cancer could be prevented if we exercise, eat right, quit smoking. And someone in the audience threw up their hand and said, where do we exercise? I don't have any street lights in my neighborhood, and my neighborhood's not safe after work. And then they said, where do I get those fresh fruits and vegetables? I don't have a grocery store in my neighborhood within 3 miles. We live in a food desert, and honestly, I didn't know what that meant. So I stopped talking, and I took out my notebook, which I still have, and I started writing down things. And that launched my interest in this community in health disparities. So I'm thankful for the opportunity to be here. I am truly the moderator. I'm not the expert. We have the experts here, and I'm going to start with David Rankin and let them introduce themselves and how they want to be known to the community.
free medical clinics, and the audience here, Dr. Tom Kent, who's just done an amazing job over the years.
Dr. Brown?
Hi. My name is Kathy Brown. I'm a associate professor at the University of Tennessee in the Department of Public Health. I started out, though, working as a nurse, worked about 13 years in ICU and various places in a number of hospitals. I've worked in public health, and so I call myself a pracademician, both practice and academia. I'm not a purist in any. Try to stay pretty involved in the community, working with getting the future public health practitioners ready and experienced, and hopefully to be part of the solution to these big problems that we're tackling. Thank you.
Dr. Buchanan?
Dr. Gray said it well. When people don't have a place to get the healthy foods they need or exercise, and there's so much more to health than whether or not you have a doctor. We have lots of doctors in Knoxville and Knox County, and even if we gave everybody access to a doctor, everybody's health would not improve. So I think that's just important to think about.
Mr. Benton?
Good morning. My name is Tony Benton. I'm the CEO for the Genova East Hospitals in the Eastern Market here. I've been in healthcare for 29 years. I started as a house orderly, and appreciate the Dr. Rose comments and the opportunity to be here with this panel. So I'm certainly humbled by the talent that we have in the Knoxville community. There are a lot of answers out there for addressing access and the disparities that we do have in healthcare. And I think a lot of that comes from collaborative efforts and being able to work together to come up with those. So excited to be a part of this panel and other things that we have in Knoxville.
Dr. Brown?
Thanks, Keith. I'm Dr. Mark Brown. I'm the Chief Medical Officer with Covenant Health. I've been in that role for about the last 7 years. I'm trained as a primary care physician. I'm trained in Ohio, so I've been a little bit all around the country. But in my role here with Covenant, we have facilities that span across 150 miles, from small rural facilities to large urban facilities, and access to care is a critical issue that we work with every day. I sit on the Interfaith Clinic Board as well, and watching folks struggle just to have sometimes an address and a loved one, we talk about that with some of our projects, it is very, very challenging. So although we have a lot of great healthcare services represented across this panel and across this community, making sure people have the ability to get those services is critical, so I'm glad to be here today.
Thank you. I think they're going to load a couple slides for this next part. Okay, no problem. No problem. So while they're switching those over, I'd just like to say, as Dr. Rankin mentioned, I'm a surgical oncologist, and I've done thousands of operations to remove cancer in hopes that I get an opportunity to offer people better quality of life and some longevity. I don't use the word cure anymore because cure is not up to me, and it's not up to us as healthcare providers. However, from a global standpoint, we spend a lot of resources and a lot of time going after cancers that are measured in centimeters. So the question is, why do we do that? Because we know that that cancer measured in centimeters, sometimes even in millimeters, has the opportunity or can impact the entire organism if not removed. That's the same way I feel about social determinants of health. It is a small fraction of our community, but if it's not addressed, it has the ability to impact our entire community, and the organism will never be as healthy as it can be unless we go after that cancer in our community. So our goal here this morning, we talked about disparities, but it's really not disparities. Disparity describes a problem. We know that the problem exists, otherwise we wouldn't all be here. We want to move toward a solution. We won't solve it this morning, but hopefully we have an opportunity to have the right people in the room to have a conversation. When I was a part of Leadership Tennessee, one of the take-home points I had was take someone to breakfast and start something. So I want to thank Knox News for inviting us to breakfast so we can start something. Growing up in eastern North Carolina, the socioeconomics look very similar to East Tennessee, but the demographics look very, very different. I had a lot of relatives, loved ones, and friends that seemingly didn't do as well from a healthcare standpoint. A lot of those relatives and friends were minorities. We had a large population of immigrant workers and a large African American population. So like the rest of the country, like the Institute of Medicine, I started to think that health disparities ran along racial lines. And so we described that to death for the first 20 years of my intro into medicine. But then we started to realize that it's really not ethnicity and race. Those ethnicities and races share socioeconomic factors that make them alike. And so the World Health Organization, I think in 2010, really started to describe disparities along the lines of social determinants of health. And as some of our public health colleagues know, these are social determinants of life. You could change health to social determinants of education or social determinants of employment, whatever. These social determinants affect the opportunity and the way that we live. What we want to move to today is what's described by the Robert Wood Johnson Foundation as promoting health equity, and how do we do that? And so that's going to be really the tone of our discussion today, is moving toward a community of health equity. I want to start with our first question this morning for the panel. How would you characterize the overall health of the community? What geographic and or demographic areas are at risk? And Dr. Buchanan, I'm going to let you start with that, if you will.
So first of all, I would characterize the health of our community as not great. We rank very low in the county health rankings across the country and within the state. Tennessee ranks 45th, 47th nationally, and then Knox County, within a state that ranks that low, we rank okay, but still the state overall ranks poorly. And those populations that are at risk in Knox County are our populations with lower income, and it does look like it falls along racial lines based on based on the mix of population that we have. So if you take any disease at all, hypertension, asthma, doesn't matter what it is, and break it down either by race or income or education, you'll see the same trend: lower income, lower education, higher rates of disease. It doesn't, even if you account for access, higher rates of disease in those populations. And that's where we as a community have to do something different to really improve the health of our community.
I want to follow up that question and say, are those geographic areas in our community contiguous, or are they scattered throughout the Knoxville metropolitan area?
I'm going to let my colleague Kathy Brown take that.
So, and thank you. It's such an important question. One of the things that, and I will speak to the geographical piece, but if I could give just another comment first. There's a concept or a description of health that has been widely discussed really around the world, and it's something that we call the gradient of health. And the gradient of health is the premise that our health improves as our income improves. And it's not just from the most wealthy to the least wealthy, but it's truly a gradient where health improves with the wealth of the individual or the community. So it's not just one group that we want to think about who's in so much need, but it's really a framework or a context that we need to look at across our community, not just assuming we fix it because we fix one little problem over here or a group of people over here, but we need to think about it in terms of the whole community. To the geography, yes, there are concentrated areas. We think about East Knoxville, South Knoxville. I was sharing that I recently moved to South Knoxville. My life expectancy based on my zip code dropped by 6 years. So where I was previously living, the projected life expectancy was about 6 years greater than where I'm currently living. So I'm really trying to live life to the fullest now. We also have areas, it's not a simple, there's not simple lines. We have areas that we call, that we can describe as concentrated poverty. It's based on areas where the population is greatly or in the majority have lower education attainment, low income, and those communities where there is concentrated poverty they have less resources. There's a little bit less of the cushion that can absorb and help people to experience some of the true impact of poverty. But on an individual level, if you're living in poverty, you're living at a stress level way beyond the person who is not living in poverty, and that's one of the other factors in this gradient of health. Those who are living and trying to seek the place to exercise or the place to get the healthy foods and are stressing about it are living with an internal environment that right from the start is not health promoting and in fact can be very contributory to all kinds of chronic disease and earlier death. So I will pause there and
Actually, I'm going to ask you to keep talking. You talk about the gradient, or you demonstrate the gradient of health pretty clearly in your behavioral risk factor surveillance survey. Talk a little bit more about the findings that you have received from that survey.
So I must acknowledge the Knox County Health Department, and I was still working there when we conducted the most recent one that's available. I believe there's a new one coming out momentarily or sometime soon. And so what we did when we put out the results of that survey, and the behavioral risk factor survey is a annual survey, telephone survey that's done. It's actually done around the country. Knox County has been committed to doing their own for quite a few years now. So there's a lot of ways to compare it to other areas, to the state, to other states, and like communities. And what we did when we presented the results of this was we presented the results by income. And we clearly it's a stepwise gradient that showed those who experienced the highest level of, and as Dr. Buchanan said, whether it be having diagnosed with hypertension, lack of physical activity, worrying, stressing over whether they can afford to access healthy food, or where they had to choose not to see a physician because they could not afford it. Even people who are insured doesn't mean they can afford to go to the doctor. And they make it's a hard decision to make, because sometimes it's, I lose a day of wages, or I go to the doctor and maybe have to spend the whole day doing that. So for every indicator, almost every indicator, there was one, and I think it was about sleep. The gradient was clear, every one of them. The poorest outcome or the poorest level of the indicator was indicated or demonstrated by those with the lowest income and that associated lowest education level. So we use education often as a proxy for income. So as our ability to provide for ourselves, and in fact, a recent conversation, one of the editors of the American Journal of Public Health wrote about how your job should be yet another social determinant of health. And so we look at what are those opportunities in communities for people to better themselves, to have a wage beyond just a living wage, but a wage where they can afford to truly be healthy. And it's not just about, as the comment has already been made, whether you can go to a physician, but it's also whether you can go to a physician and access your medication, keep your prescription filled. The price of insulin right now is outrageous. I live with an insulin-dependent diabetic, and we can afford it, but it is absolutely I think it's a death sentence for many people. Who is most affected by diabetes, especially poorly controlled diabetes? People who are lower income, lower education attainment. They don't have the same level of resources. And it's not just the resources of the medication or the food, but it's knowledge. And it's access. You can go on your computer, you can become an expert in a disease, spend a week on it. If you don't have that same kind of access or the literacy to be able to process the information and integrate it into their how we all live, it's hard. It is really hard, even for some people who, I've been to school, I teach at the university, and I will tell you, managing some of these chronic diseases tests the capacity and ability of what some might consider someone who's at least a little bright. I got through, UT a couple times, so there's something to be said for that, but it's hard. And we just expect people to be able to go out and be healthy and follow. I'm trying to throw out the term non-compliant patient. I find it almost insulting at times, because it's not because people don't want to be healthy or they don't want to get their meds or understand. They lack often capacity, ability, finances, and support. I better pause because I think I'm going to
Mr. Bent.
I would just add one piece to the disparities in health. Certainly, I think the rural aspect comes into play, that when you look at patients with complex chronic conditions, getting to the mailbox is a challenge for these folks, and when they're trying to access daily treatments, whether it's radiation oncology or dialysis or those types of things, the rural aspect and the access is a big challenge for our area, and that's particularly important in Tennessee.
So along with that, actually that leads into my next question. I was going to ask, what impact on individual health, which we've talked about, but also on healthcare systems, have you and Dr. Brown seen when people have poor access to timely care? And I differentiate your systems from the University of Tennessee. We have satellite primary care facilities, but you guys have major parts of your system that serve the rural portions of our East Tennessee community. So Dr. Brown, talk a little bit about what you've seen and what the impact has had on your system.
Thanks, Keith. One of the biggest impacts that we've seen, I'll give you both a negative and a positive.
Sure,
I'll do the
absolutely.
negative first. I think anybody who's been to any emergency department, whether it's mine or yours or any one of yours, Tony, knows that is probably the worst place to access health care, but the place that most people go to, because it's always open. It's open 24/7. It's one of the most expensive places to get health care. And although we have great emergency care around the city and around all of our surrounding areas, it really is not the best place to get real health care in terms of the longevity of that care, management of chronic care, et cetera. And unfortunately, that's the place where people tend to go first due to lack of other places of access. So that, I think, is a real challenge for us because, as we know, it's harder and harder to get through an emergency department. I'll give you a positive, though, that we've seen. You heard me mention before, Keith, one of the biggest challenges after you've been in the hospital is maintaining your care after you leave. Hospital stays are shorter and shorter, as Dr. Rowe was talking about earlier, and when you're in the hospital 3 or 4 or 5 days or less for a chronic condition, and then we expect you to go home and just do well. As the other panelists were talking about, can be a real challenge. And one of the challenges that we've seen is simply having an address and a loved one to help care for. And with our homeless community here in town, and one of the things that we've done recently as an experiment, and it's about 4 months old, so knock on wood, I think it's working relatively well, is partnering with Mr. Rosen and our partners down at CARM to try to find a way that when someone could go home, but they have no home, how do we do that? And so we've partnered with them, with Trinity Foundation, to have I hesitate to call it a unit, it's not a unit, it's an area down at CARM where we can send our patients where they simply provide an address and a loved one, someone who can sit with them while our home health providers come to them now that they have a home. You'd think it's simple, but you can't have home health care if you don't have a home. It also provides another level of safety for our providers, for our nurses, that they're not traveling all over the county and everywhere else, and to areas that may not be safe or as safe for someone to travel into alone. So it's provided a new access point to care. We've had a couple of dozen folks who have used it. We've saved over 300 days in the hospital. 15, 16 days on average that people would have stayed in the hospital to get their care, and now they're able to get that care at their sort of peripheral virtual home through CARM, and they're able to then coordinate some of the other systems that where people can get access. And I think that's one challenge I hope you'll talk about, Keith, is we have a lot of great things in town here that can provide some support. Coordinating those resources has been a real challenge, I think, for our community. There's been a lot of attempts, and good attempts, through Healthy Communities with Humana, through some things the health department has done. We all get to sit on the same panels a lot. Martha and I joke about that a lot. And there's been some good work done, but I don't think we've really solved the problem of coordination of all of the resources that we have here in the community.
Mr. Ben, you want to add anything to that impact on your system?
I would say, from an impact perspective, one of the things that we see as a result of those that don't have that access or the disparities is delays in care. And so if a patient is not getting, screenings, well, they're not even a patient often, that when they're reaching our healthcare systems, they're much sicker and much more advanced in their disease processes, and I think that is a big challenge, and trying to combat that is to open up additional access points to make sure that folks have the ability to get preventative care, primary care, in settings that are easy to attain. Doing things. We've put in places 24/7, physician access centers that can get patients scheduled for care, making sure, if people are in the hospital before they leave, they have follow-up care already scheduled. Things like that are very important for our patients.
Thank you. Dr. Brown, you kind of alluded to my next question, which I want to address to Dr. Rankin. There are a lot of things being done in this community. There are a lot of people that care for the people in our community who are less fortunate. But the problem is where there's overlap, there are gaps. And I know some of the work you're doing. I want you to talk briefly about that, but also talk about do we know what's being doing, and what are the initiatives that have been impactful, and why do you think so? Take the first part, talk about what you're doing, and then talk about other initiatives that you're aware of that have been impactful.
About 2 years ago, a lady named Sandra Fugit we go to church with. She teaches English as a second language at West Lonsdale Baptist Church. She was actually in the Burundian church to begin with. And so we were talking, and she said, there's a real need for these folks to see a physician. So my wife's an RN, Susan, and so we said, well, we can go over there on occasion and just hold a medical time. And then through the work of God, there was a pharmacist who came and worked with us, Lisa Lawson. And so we have a medical clinic that we meet about once a month and gets the word out in the local community there. When I say local community, it's the Lonsdale area where we are mostly. You may not know, I'm sure you know, but there's at least 1,000 Burundians. You may not know where Burundi is, but you've heard of the Hutus and Tutsis. And can't remember where it's the Hutus or Tutsis that ended up going to Tanzania. But Tanzania no longer wanted those people, so a lot of them came to Knoxville, and there's thousands of other places. There's thousands of Guatemalans here, Iraqis, and a lot of those people don't speak English. And besides the problem with the not having enough money, if you don't speak English, you really have a problem in America. So it's been a great joy to do that, and we've made a very small impact. I know that the Emerald Youth Foundation has started a clinic, or will be starting a clinic not too far from there, that Cherokee Health is going to man from a physician standpoint. So these are small things that I think make a difference. We do get, like I said, people from all over the world. We've had people from Ukraine, Russia, to go on. But these are folks in need who don't have access to care. And so I would like to see more than this, but it's really a drop in the bucket. This is not really the answer. Our goal at our medical clinic is to help people, but actually our real goal is to tell people about Jesus. Our thing is that it's much better to join a church than a gang. So we're hoping to make a difference.
Thank you. So we're going to take this last 10 minutes before we open up to question and answer and talk about what health equity looks like in this community. And I'm going to open up and whoever wants to take that. What's, in order to pursue, you have to, most of us have mission, vision, and values for our organization. That vision, at least for the last 3 months for me, I get up thinking about that every day. Are we moving toward this target that we have set for ourselves? So we have to know, at least in our own heads, what that target looks like. So what does health equity look like in Knoxville, East Tennessee community? Dr. Buchanan, you want to start?
Sure. It's kind of simplified, but I think Kathy, Dr. Brown said it well. When she moved to South Knoxville, her life expectancy decreased by 6 years. And I think health equity in our community means that doesn't happen, that your health outcome and your life expectancy is not determined by your zip code or your income or your education, but that we have equal playing field. And our vision at the health department is every person a healthy person. But in order to achieve that, there's so much other work that has to be done to address education and income. And if you think about the folks that come into the ER and get sent back to that home, whatever it is, with the lack of resources, how can they be expected to carry out what needs to be done to address their diabetes or hypertension or whatever else it is when they're just trying to survive? So that we have an equal playing field, and if you live in Knox County, your life expectancy is not determined by your zip code.
Dr. Brown, Covenant's vision for that.
Well, I kind of touched on it a little bit already, Keith, and I think, and I echo what Martha says, I think the first part starts in places like this today to have a greater awareness of social determinants of health. I loved your story at your beginning of your journey on health equity, and I think if we're honest with each other, many of us, probably in this room and many of our colleagues, don't really have an understanding of what those different social determinants of health are. The other thing that I'll just echo from my previous comments is the coordination of existing resources. I don't think we have tapped into all of the resources effectively that we have here in this community, and finding ways not only to provide access to care, but to have access to those services for those who provide care. I'll give you an example. Kaiser Permanente out on the West Coast, who doesn't do everything well, but they do some things well. We're in this whole other discussion, maybe a different panel, Keith. But one of the things that they've just begun is a project called Thrive Local, where they've integrated all of the access points into the electronic health record of their health system, so that a provider can actually go in and place an order that says, I need to go to the Interfaith Health Clinic, I need to get CSC, any of our local services. We don't have that right now. Not only even an awareness of what all those services are, but the ability to say, I think one of my patients might need some of that. And even if we just had that level of awareness and build it in to make the right thing to do, the easier thing to do, I think we could make some leaps and bounds.
So for those of you that were at the Emerald Youth Breakfast, I mentioned this, but 2 years ago I had the opportunity to sit with Mr. Bill Sansom and Jimmy Haslam when we were talking about the Lonsdale Ministry Complex, which is going to house our health center. And one thing that Jimmy Haslam said that stuck with me, he says, when I'm in Cleveland, none of these problems are solvable, but Knoxville has a solvable problem. And so based on its size, based upon the people like you on this panel, based upon the people that are gathered here, we have enough concern, we have a small enough problem, and I think we have enough diverse resources to solve it. My next question, maybe the last question, is who needs to be at the table? Clearly we're all part of the healthcare community, but what other organizations, industries, disciplines need to be based on those social determinants of health, which only one circle is related to health? Who else needs to be at the table? David, I'll let you start with that.
I think probably everybody ought to be at the table, but especially industry. And this is, if they consider this their community, then they should be pouring time and resources into helping our folks. and it sounds like from what we talked about, with the income and the .71 that Dr. Rowe talked about, that's a problem.
Yeah.
And it's also a problem with the insurance companies. And you'll see last year, the Blue Cross Blue Shield is a not-for-profit. They made over $487 million. This year, they're going to make over $1 billion. And Dr. Brown, what did you say United Healthcare is making per quarter?
Oh, it's probably 3 or 4 times that. It's an astonishing number. It's a lot more than most health systems. Let's put it that way.
So I think the health insurance should be a big part of that too, and I think that's a problem too.
Dr. Brown, who would you add to that list?
Well, our health is not the result of just our physician or the bricks and mortar healthcare in a community. So it's education, and I want to identify a group that's part of the solution. I think it's the Great Schools Partnership that really works to bring the community together through the use and through the opportunity that the education experience provides. But it's the criminal justice system, it's business owners, it's large industries, small industries. Excuse me. This is something that we all share, and we can all be part of the solution to. But we've got to move it out of the realm of health. It's the doctor's business or the hospital's business, and it's their responsibility. It's a shared responsibility. I'd like to say, to echo everyone in the community, but certainly even those who do not consider themselves, excuse me, part of traditional health care. It truly is a shared responsibility for everyone.
Dr. Buchanan?
So, yeah, thank you. So I would add to the list of folks who are looking at this and considering the health of our community, the big H, as we're calling it, the health department. The Community Health Council is very much involved in that, and it's a diverse group of leadership in our community. And, in addition to what Kathy and previous speakers have said, I think we need the community, members of the community who can provide input. We can sit around as leaders all day long and talk about solutions, but if they don't work for the people we're trying to help, we really haven't accomplished. We've made ourselves feel better, and we do a lot of that. We come up with an idea and a solution and go, yay, we fixed it, and we didn't. So we need to involve the folks who are impacted by this problem.
Yeah, in my limited, I know enough public health to be dangerous, but I know the first step in solving the problem is a community assessment.
That's right.
And getting buy-in from the community members themselves. So, Mr. Benton, you want to end?
Other piece, when you think of the determinants, you have to talk about the cost of care, and cost of health care is very, very high in our country. And you have to also include, I believe, the industry, pharmaceuticals, implant device makers as well. And some source of the frustration, I think, on the hospital side is in that cost to deliver care. And provide an example of that. There's a procedure that the actual implant costs the hospitals $32,000 for the implant. Medicare, with the Medicare wage index, as Dr. Rowe had talked about earlier, pays the hospital $31,000 to do the whole procedure. And so you're getting reimbursed for procedures that you're not even covering the implant costs. And that certainly points towards some of the pharmaceutical device and implant makers that need to be part of that solution as well.
Thank you. I think we're right on time. Christy, right? Okay. Anything else panelists would like to add before we open the floor for questions?
Just one more comment, Keith, on folks who I think need to be at the table, and I think it's sort of been woven through our conversation, but not specifically said. Some of you probably know, but I'm not from here. I was originally from Ohio. I've been in Knoxville for 10 years, and one of the unique things I found in moving to the South is that there is a unique thread of a faith-based community of many different faiths that run through the South, and in particular here in Knoxville, and that really is the cornerstone of many of our local communities. And we're blessed to have folks of lots of different faiths, and those are gathering places, those are community places, those are places that people can speak to people simply and help understand and provide education. And I think we do leverage that, but I think leveraging that even more is an opportunity that's unique to us.
That's awesome. Thank you. We're going to open the floor for, we've got many experts in the audience that are working on this issue. Beth Hamill, Dr. Kim, others. I'm going to open the floor for questions or comments even related to this topic. Dr. Kim, yes, sir.
This is pathetic. Are so bad in Knoxville here. Any doctors here? Nobody, except our panels of Gray and Rankin and Buchanan. This is so bad. You know, we should have more other people come and listen to our program in Knoxville area. Look at it. It's less than 20 people is here. And we needed to, next time, you know, do better than this. Because you guys have to work. I got to go work in a half an hour. They took a time out to try to solve our health care around this area. Look this. The reason I came here is Dr. Rowe, he married my classmates at Johnson City, Milligan College, 50 years ago. I know them well. And then, second reason I come here is you're a physician. What the heck are you going to the politics? I'd like to hear from your heart. But he took off, but and another one, Dr. Rankin has kept me, my family, my health for a long time. He's my physician, and Dr. Gray know him so well, and Buchanan, and I don't know you guys, you're late. But again, next time when you're gonna have it, let's do maybe $25. I'm afraid to come over here. And timing, Monday is a very busy day. Everybody knows that, right? So the time and then the price to attend it, you guys have to really think of it if you want to continue to have this. I'm glad you guys had this first one. Thank you very much.
Good morning. My name is Cynthia Finch. I live in the community. I actually do hands-on care. I want to echo what Dr. Kim has said in regards to if we are going to involve as many people as possible, those same people Dr. Kim's talking about, they're at work. The folks that we are wanting to serve, they're at work, okay? So as we plan opportunities to have a discussion, we need to make sure that we know when we're going to get the most impactful participation from folks. Okay, that's my soapbox now. But I got my two items here. I know that Dr. Brown talked about this whole important piece about coordination. I'm a clinical social worker. I'm halfway retired, but you know, people say you retire to work. So I'm still working, and they're still calling for me to come to hospitals, to your hospital and that hospital, in regards to coordinating care. That's because I have a deep understanding about resources. I work with the free medical clinic that is housed over on Magnolia. We meet every Monday from 12, it's open today, from 12 to 6. Dr. Janet Perkey, that's at your hospital, UT Hospital, is our medical director. Dr. Bashur, Dr. Otis, Dr. Betterton, and then even Dr. Chris Sawyer came last Monday. And we are seeing patient encounters anywhere from 50 to 60 to 70 people every Monday. And they're coming from all over. Now with Dr. Kim, his free medical clinic pulled back a little bit, we're getting a tremendous influx of people coming to the free medical clinic. And thank God for Dr. Betterton, who was approved during Hurricane Katrina to have a mobile pharmacy. We're able to give out the basic medicines. We don't do any Schedule IIs, but blood pressure, those kind of things. So I say in regards to coordination, how many of you all knew that there's a free medical clinic over on Magnolia at the church? How many of you all in this room know about the free medical clinic? How many knew about Dr. Rankin's free medical clinic? If I could say anything about these hospitals, your case managers, your social workers in your hospitals, you need to make sure that they know about all the free medical clinic. Then I'm sorry that the mayor is not here. Here's the mayor here from Knox County. I was reading in the newspaper that they're talking about pulling back some of the monies from the indigent care program that's going to be devastating for the UT Medical Center, for Cherokee Health System. That we all as voting citizens need to be in his ear about what we're going to do about that money that they're talking about taking away from the indigent care pot of money. Yes, we need infrastructure, we need this, that, and the other, but we got a lot of folks that need what we do with the Cherokee Health System. And I want to commend the Knox County Health Department and all the things that they do, and Dr. Brown, the UT. But when I think about access, and you go from all the way from the old restaurant that starts down at downtown and go all the way past the Waffle House on Asheville Highway, you can just count on one hand the number of healthcare concerns that are in the East Knoxville area. It's just not in the 5 points. We're talking about going east, north, south, and west. Their health access is a problem. And in order to get to a big campus of care, you got to go all the way from there to UT Hospital. I guess it's the closest. Then you go over to Fort Sanders or Covenant, no, Fort Sanders. But there is a problem with access. So coordination of care, the knowing what's going on in our communities, making sure that if there's opportunity to have dialogue, and you want to hear from the people that really knows what the problems are, that we make sure that that is convenient for them to participate. Then in regards to, I made a note here about coordination, because I'm real big on this whole issue about coordination. How many of you all know about the MIH system that's already been coordinated through the University of Tennessee, that is a system mainly for the homeless, but it also could be expanded and have, it's where all the organizations are in a system, and if a homeless person comes to your place and this place and this place, you can go into the system and see if they're going to multiple places getting the same thing. Well, that could be expanded, possibly, to take care of another population of people, these other folks that we're talking about. So that's just one idea. Then the last point that I wanted to make is I was so happy that Dr. Rowe talked about NIH. They got tons of money, tons of money. And I do see that the University of Tennessee, Knoxville, Dr. Brown, in the various departments over there, like the UT College of Social Work, I'm a UT alumnus, and I see they announce occasionally at the veterinary school and so forth that they're getting research monies to do care and find solutions to things. So I would suggest that as we begin to try to pinpoint some of the solutions, that we actually see how we as a collective community could tap into NIH and get some of their big dollars to do some of our planning, our implementation, and our impactful desire to do better, and that makes our community healthier. I'm willing to be remember I told you I was retired, semi-retired, retired to work.
I'll call you.
I think I would say just a couple things. That the coordination of care is really critical, and I think Dr. Brown even mentioned that earlier. Is there are a lot of great resources here in the community. I'm on the board for the Knoxville United Way, and I think to your point exactly is being able to spread the word of what's out there. Certainly, a lot of us are in the healthcare circles, but getting that message to the folks that need those services is critical, and make sure that they can access those. But your point's a great one, and I think that's a huge opportunity for the community.
You mentioned one other piece, the MIH system. I'm glad you brought that up, and we should add that to the list of folks who need to be at the table, are the information technology folks. I think, without getting too deep into this discussion, even though UT and Covenant have the same vendor that provides electronic health records, it's very difficult for our systems to talk to each other. They're not designed that way. It's not a UT thing or a Covenant thing. It's designed not to be able to work that way. The MIH system is a great system, but it doesn't integrate with other information technology systems, unfortunately. I think having those folks at the table and having them contribute to the solutions, both financially and innovatively, is another good idea. Thank you for that.
Okay. Hi, I'm Jessica Waddell. I'm Director of Community Programs at Susan G. Komen. I'm also the co-chair of the East Region Tennessee Cancer Coalition, which is a statewide effort with my chair, Beth Hamill. And so I have a quick comment and then an ask. Hopefully I'm not going to get this feedback too badly, but it's very comfortable for us to rebrand the racial inequalities as solely being about socioeconomic status and social determinants of health, but I think we need to recognize that one of those social determinants is individualized and institutionalized racism. When we see the racial disparities in breast cancer, where Black women are less likely to be diagnosed, but 42% more likely to die, that's independent of income. So regardless of how much that woman makes, if she's Black, she's more likely to die. Now, we do also see that same statistic in those of all races who are at a low socioeconomic status. But it's important not to just gloss over the racism. Recent research shows that the biggest cause of this disparity is inequities in treatment, meaning that Black women are receiving less treatment, less quality of care, fewer treatments than their white counterparts. And that brings me to my ask. We have our next Tennessee Cancer Coalition meeting this Wednesday, May 22nd, from 2 to 3:30 p.m. We'll be at the Provision Proton Cancer Center in Knoxville. I'll be around. You can get the information from me. As an organization, we collaboratively aim to reduce or eliminate the disparities in this region in both lung and breast cancer. And we're going to be talking about the soon-to-be-published 5-year cancer control plan for the state, which we helped draft, and how our region can collaboratively come together to address these inequities. And I think the first step is going to be better understanding what the landscape is and the causes are in our region, because Knoxville's a lot different than, say, Memphis or Atlanta or these other areas where you see that same disparity. So that's all I've got.
I want to respond to that, and thank you for your comments. We don't mean, or at least I don't mean to dismiss race as a independent factor, if you will, especially when it comes to healthcare bias. Bias exists in healthcare for a lot of different reasons, other than race, but race is obviously included. Some of the things that we're doing, at least at the University of Tennessee Medical Center, is trying to promote diversity in our workforce. People do better with people that look like them. And again, I think that's a doable thing here. We were in Chicago and Atlanta, where the minority is the majority. Pretty hard to do, because the population that we have to choose from for healthcare providers is much smaller than the representative population. But here, I think that is a doable thing, and we're making those efforts in our workforce to have people that look like the people that they care of.
I'm a pastor at a local church, and my ministry is oriented towards the large group of people who work at Weigel's and then move and work at Domino's and then go down to the restaurant and wash dishes, and then they're back up at the Shell station, and they spend most of their lives making $10 or $11 an hour. And I'm mostly focused on these young women, and I'll be talking, I don't ask this question anymore, but I used to ask, can your mother not help you? Well, my mother had me when she was 16, and I had my baby when I was 17. Now, currently I'm working to support a young woman who was raped when she was a senior in high school, and she's keeping the baby. She's had the baby now. But one of the most frustrating things to me was she was somehow allowed to drop out of high school because she was so traumatized within 4 months of graduation. It was all I could do to keep from strangling the principal. But to me, I see a cycle with this group of people over and over.
Good morning. Thank you to the panelists. I'm Dr. Brian Kessler. I'm the Vice President and Dean of Lincoln Memorial University DeBusk College of Osteopathic Medicine. And one of the things that we have is we're really blessed in this area of having several healthcare institutions, training institutions that are training the new leaders and the health educators and physicians, PAs, nurses of the area. As an educator, what can we do better, and how can we help you kind of change this?
That's a great question. And one of the things in my public health education was kind of like what Dr. Gray said, the understanding that not everybody, when I send them home, has the same access to the things I'm expecting them to be able to do. So, that diabetic that you're taking care of who just doesn't have access to healthier foods, to start to understand that. And there was a study in Boston similar to the writing a prescription for access to social services, and it made a difference. People stayed out of the ER because somebody helped them get what they needed to be compliant. And it just makes all the difference in the world if the provider understands that everything I'm asking this patient to do is the decisions are made in this context that I have no understanding of because I don't live in that world. And even culturally, when we're talking about management of a chronic disease, to culturally understand that the cultural diet or traditional diet of whomever you're speaking to might be really different from yours. So teaching the social determinants of health and that your patients live it, and you have to understand it to really provide the care.
Brian, I think that at our organization, one of my goals as the new chief medical officer, really top of the list is to educate our team members and also new hires on the social determinants, so that you have a different lens. You know, no longer is it the patient's fault that they missed their appointment and 3 people took time off work that didn't have PTO to get that person there, and then they got to the organization, they couldn't find a parking space, and so on and so forth, and the list goes on and on and on. But to look at these patients that are having difficulty with the health care and ask the right questions to get to the root of the problem, then start to solve the problem, and then we don't have the problem anymore, but not just to assign blame to the patient.
Brian, I think Keith illustrated it well with his first story. You know, 2 of the biggest gaps, I think, in medical education, at least from back when I trained, I'm not going to tell you when that is, but I think it's been improved somewhat, but the education around public health, period, and that as an intentional exercise, not just an hour presentation or someone like Keith coming in, which is great, but having a very focused piece around public health and really what that means, because I don't think most of us came out of medical school, and even today come out of medical school or other professional schools knowing really what those resources are and how to access them. And the other real piece, I think, is nutrition. You mentioned diet. Doctors aren't very good at it, big secret, right? We don't get taught very well on how nutrition really impacts healthcare. I think focused education in those areas is another opportunity.
So my daughter just finished her 2nd year at Vanilla. And so I also know that she's being taught that she should have a history and physical with the patient, and in the electronic medical record, I think 25 minutes. I can't even say hello in 25 minutes to my patient. So I think the most important thing is to understand that when somebody comes to see them, they're not a disease process. They're a person, and they may have a disease, but they may be there for a completely different reason. And I think, at least as a primary care physician internist, I'd say at least 25% is probably a lot higher than that, or just talking to people about what the problems are. So that would be my suggestion.
Yes, sir.
How would this picture have changed had 3 or 4 years ago the state passed Governor Bill Haslam's Insure Tennessee program and expanded Medicare in the state?
You want to take that Who's going with that one? So, jumping in politics. No, I think, again, you know, one person's opinion, I think, would have potentially helped in a lot of different ways, and we've talked a lot about access, and that is an area that certainly helps in providing better access to care for patients to get them the treatments that they need. You know, I'd mentioned earlier, one of the biggest challenges is that a lot of the patients we see now in the hospitals have delayed care, and they're coming in, and the condition that they had is now much more complex, and they're much more acute in their disease processes. And so I think that without getting into too many of the politics, I think expanding that access would absolutely have helped. And you know, we've had to do a lot of difficult things with our hospitals to reposition our services because of those reimbursement rates that we receive in this area that Dr. Rowe had alluded to. I think that definitely could have helped to sustain some of those services that we had as we've gone back and a little bit of a retrenchment, and then, you know, providing services now that are sustainable and looking at different access points. We are growing our services in the Easttown area, the Genova South areas, and so really trying to make sure that that access is available out to the community.
I think it helps the working poor. Honestly, I think we all know that, but it clearly doesn't solve the problem. It only addresses one issue up there, that's health and care. From a standpoint, as Dr. Rankin was mentioning before, fear, trust, health literacy, still doesn't address those issues. So the burden is really on us to go out and as Dr. McKinnon talked about before, doing a community needs assessment. And I think the needs of each one of these disparate communities is likely unique, but there's also some overlap. But really defining a program and that targets the needs of a specific area and not making assumptions.
If I could just add a comment. So we are in Knox County, our current rate of uninsured is almost 10%. We have, someone can correct me, I think somewhere around 455,000 residents in Knox County, give or take a few. So that means we have about 45,000 people who are uninsured. That expansion likely would have helped bring that number down. So more people would have had access to insurance. I will just say, though, that looking at that number alone is not sufficient because we have so many people who are insured, but they're not well insured. They don't have the kind of coverage that also allows them to access care. They may have very high deductibles. They may have very high copays. So just having the card doesn't assure access. So we really, from a policy standpoint, have a whole lot to do thinking about what we want as a community, a society, a nation for the residents of of this country and what it's going to look like. And if we are okay with having free clinics in various areas and piecemeal health care and people who enter hospitals with advanced stage and comorbidities and advanced stage disease, which is a higher cost to the hospital system, then we'll continue on this path. But if we want something different, it's going to be, it's very difficult. It's not a simple problem. It's not a simple solution. But I'm hoping and praying the solution actually is out there. So that might have helped some if we had expanded.
I want to close by saying that, you know, we have 4 different systems really represented, 5 different parts of our healthcare system in Knoxville represented on this panel. 3 of us compete with each other for market share. We try to out-market each other and do a better billboard than the other person. But I think this is an opportunity for us to link arms and solve a problem that's common to the people of this community. I want to say Dr. Brown has been very supportive of me as a new CMO, giving me a lot of advice. We probably text or talk by phone once a week for the last 3 months. I think we can do the same thing to solve this problem. And I think it's really, I guess it's a question, maybe it's rhetorical, but is this an opportunity, is this a kickoff session to form a collaborative effort to solve this problem in this community?
A question just briefly. So if the people that we're trying to help that are not getting equal access to health care, I'm just curious, that's something you'd mentioned, how do we increase diversity in healthcare facilities and empower these people who are in a place in their community where they can't reach those, have access to healthcare? How do we increase diversity in healthcare facilities? And then how can citizens that aren't, you know, as tenured or as experienced in healthcare be a part of this solution?
Sure. I'll go to the diversity issue. So diversity means a lot of different things for a lot of different people. At least in my head, talking about the vision statement, the goal for diversity in our organization is that we represent, that our medical staff and our team members look like the population. For example, that doesn't mean we're going to get 13.5% African American providers, because that's a national number, that's not a Knoxville number. And so our goals have to change to represent the population that we serve, I think is the first thing. And for people, we're likely to draw people from our community and have them go into healthcare in that same community. It's pretty hard to bring people from outside of the Knoxville metropolitan area and have them want to practice healthcare
here when they can live in Charlotte or Nashville or Atlanta and some of the other competing places. And so, therefore, we have to mentor young people that are interested in healthcare, expose them to healthcare early on, not high school. High school's too late. You're taking the ACT, and you can kind of box yourself out if you're 14 or 15, which is what some of our schools here in disparate areas, their average is. We got to start in middle school, 6th grade, 7th grade, 8th grade, and empower people and let them know that they can be healthcare providers, not a nurse, not a tech, and nothing wrong. I'm not saying that in a disparaging way, but they can be a CEO, they can be a CMO, they can be a physician, they can be the head of public health, they can be whatever they want to be if they know what it looks like. And so that has to start early. And so the reality is, are we going to sit under the trees that we plant? Probably not. We're working on a problem that's probably going to be solved long after all the people in this room are gone. So, but we just have to be willing to do that.
Yeah, just have a quick comment. As far as helping those people who don't have the ability or the experience in healthcare, I think local churches would be great.
Well, first of all, I'd like to, I'm loud, so I won't let it run the sun. My name is Frank Rosamond. I'm with Knox News as well. I just want to thank all of you, first of all, for coming this morning. Thank you to the board for coming in. Thank you, Dr. Gray, Representative Dr. Phil Will for coming in, taking his time today. We know this is just scratching the surface, but we felt it was important to at least begin the dialogue, and so we know there's a long ways to go. But we appreciate your time this morning. We appreciate all of you coming in, and as stated, hopefully it's the beginning of something important. So with that, thank you for coming in this morning. Have a wonderful day.